Hi, my name is Dr. Don Buford, and the title of this presentation is Biologics for Cartilage Lesions, Non-Operative Solutions. This is being presented at the 2024 ANA meeting, currently being held in Boston, and I appreciate the invitation from Dr. Frank and Dr. Tokish to be one of the presenters on this topic. These are my disclosures. They're up to date on the AAOS website. I can be found in all these different social media outlets. So I'm going to start with something a little bit unusual. I'm going to start with the conclusion. As of today, there is no peer-reviewed, proven injectable biologic that can regenerate significant hyaline cartilage. We can't correct joint alignment. We can't remove osteophytes. And as of today, we cannot heal a discrete chondral lesion just with an in-office injection of an orthobiologic. Now, that may change when we start talking about scaffolds, but with the current technology and the current clinical science we have, we can't do that yet. However, there are several injectable biologics that can minimize clinical symptoms from cartilage lesions. We can minimize or stop cartilage loss. And I'll show you in these 5 minutes that we can also significantly delay or possibly even eliminate the need for joint replacement, for example, a total knee replacement in certain clinical situations. So which orthobiologics are we going to focus on? I have to focus on FDA regulatory compliant choices. And as a result, we will focus on 3 in this presentation: platelet-rich plasma, bone marrow concentrate, and adipose or microfat. I'm not going to talk about any of these products at the bottom of the screen because they don't have an on-label FDA-approved indication, so I can't use them yet. Let's talk about the evidence for microfat. This is a 2022 level 1 study that compared the lipogems process with platelet-rich plasma. They had 2-year follow-up, and they did a reasonable job quantifying the PRP as a comparison treatment. They told us that they drew 150 cc's of blood. It was a 2-spin system. They were shooting for a platelet count of 1,000, but they didn't quantify it. So this is a little bit of a guess, which is why there's question marks. If they hit that target, then that would suggest that their PRP dose was 5 billion platelets versus this lipogems microfat product. So what did they find? Both worked for 24 months with no significant differences in outcomes. Patients with higher grade osteoarthritis did better earlier with MFAT, but the results were equalized for some outcomes at 6 months and by all of the outcomes by 1 year. So in my opinion, with a comparison study without a clear winner, I look at other factors like ease of use, adverse events, which in this case, the MFAT group had 19% rate of adverse events versus the PRP group at 11%. Important to note that wasn't statistically significant, but it was a clear trend. And then the other thing that I often look at to evaluate what to do if the outcomes are the same is, of course, cost. So let's talk about the evidence for PRP for osteoarthritis. This 90-year-old rock star patient came in to see me 2 years after a single high-dose injection for KL4 changes in her right knee. I was ready to tell her that it was just time to get the knee replacement if this wasn't working anymore. And she said, no, you're misunderstanding me. I want you to inject my left knee with PRP. So we did. Here's the evidence that supports doing that. In this study out of China, published in 2022, this was a level 1 study, and the protocol for PRP is important to distinguish here. This was a study with 3 injections spaced 1 week apart. It was an extremely well-powered, if not overpowered study with over 300 patients in each treatment group. The authors did a great job quantifying the PRP. They tell us it's a 2-spin system. They told us how much blood they drew at 50 cc's. They made 5 cc's of PRP. The platelet count went from 194 on average to 832 in the PRP. And if you do the math across the bottom line, that gives you a platelet dose of 4.2 billion platelets. So the patients got an injection, 3 injections. Each injection was 4.2 billion platelets. And so now we know what they did. These are the results they got. The normal saline group had better scores at 3 months than at baseline, which continues to suggest what we know, that normal saline is a treatment, washes out the synovial environment. They also found that the PRP group had better WOMAC and IKDC scores that lasted 2 years. At 5 years, the PRP group had tibiofemoral cartilage volume decrease of only 1,171 cubic millimeters. The normal saline group decrease was almost 50% more. This difference in cartilage loss was highly statistically significant, favoring the PRP group. Another way to say that is the PRP seemed to be a disease-modifying treatment for these patients with knee osteoarthritis. So let's look at the evidence for bone marrow concentrate for knee osteoarthritis, because I think you'll be surprised if you haven't seen this literature. In this level 1 study published in 2020 by Philippe Hernegal and the rest of his team, they asked a very elegant question. Do patients do better with an intra-articular BMC injection, or do they do better with an intraosseous BMC injection? So they set up two comparative groups. One group got intraosseous, the other group got intra-articular BMC. They followed these patients for 15 years. 150 cc's of bone marrow aspirate was drawn. That was centrifuged down to 40 cc's of BMC. And then the beauty of this study, the two different knees were on the same patient. So the patient was his own internal control. 20 cc's was used for the left knee, 20 cc's was used for the right knee. And you can see how they divided it up in the graphic below. 10 cc's in the femoral condyle, 10 cc's in the tibial plateau. The other knee got the intra-articular 20 cc injection. Some other interesting quantifying notes: the centrifuging process increased the mesenchymal stem cell recovery by 4x. So they went from a bone marrow aspirate count of 1,534 to a bone marrow concentrate MSC count of over 5,700. So centrifuging matters. The other thing that's important to note is that by injecting over 100,000 MSCs in the subchondral location, this is a 60 to 200% increase in the quantity of subchondral MSCs. So it truly is refilling the stem cell bone bank, if you will. And maybe that's part of the reason why it's clinically successful. The results were fantastic. Both groups had significant pain relief. The intra-articular group had significant pain relief that maxed at 1 year, and by 2 years was not statistically significant. However, the subchondral group still had significant pain relief at 2 years. This is becoming an office-based procedure. There are clinical researchers and lecturers that are showing us how to do this in the office with well-done nerve blocks and local anesthetics. The rest of their results were equally fascinating to me, and hopefully to some of you. The knee that got the intra-articular injection had a decrease in medial compartment cartilage volume at 2 years. That same knee, on 18% of those knees, increased by 1 KO grade by the 15-year follow-up mark. The other knee that got the subchondral injection had a 2.1% increase in medial compartment cartilage volume at 2 years. And in the knee that got the subchondral injection, only 3% of those knees increased by 1 KO grade at the 15-year follow-up mark. So again, even more than PRP, this was an even stronger disease-modifying treatment, if you will, because the medial compartment cartilage volume, it wasn't just slowed down in its loss, it was actually increased. And then here's the final coup d'etat. The intra-articular knee had a 4.6% per year progression to knee replacement, and that knee replacement was done at an average of 7 years. 45% of the knees that had the intra-articular BMC progressed to a knee replacement. The knee that had the subchondral injection, only 1.3% per year progressed to a knee replacement at an average of 14 years. And only 1 out of 5 of the knees that got the subchondral injection progressed to knee replacement. Again, pretty strong evidence that this is a disease-modifying, or at least disease-delaying therapeutic intervention that we can do, in some cases, in the office. Good prognostic factors: we want the bone marrow lesion to be smaller at 2 years, and we want to use higher MSC counts. Those are two things shown in the study to be clinically significant. So my conclusion, again, we still don't have the evidence that we can correct or fix a discrete chondral lesion in the office. Maybe one day when we have a scaffold, we can put it in the office soaked in autologous BMC. That will be a good thing to do. But I think we can agree now that there are several injectable biologics that can minimize clinical symptoms from these cartilage lesions, from osteoarthritis. We can stop or at least significantly delay cartilage loss. and we can certainly delay the need for joint replacement based on the work of other authors like Philippe Hernegow. Thank you very much.